In 2017, the World Health Organization (WHO) listed oxygen as an essential medicine. Despite this, many low and middle-income countries face a severe scarcity or unreliability of oxygen services, especially in small health facilities serving poor, rural, and marginalized populations. For example, in Africa, an estimated 7 million children with hypoxemic pneumonia need medical oxygen therapy annually, yet only 1 in 5 receive it. In Kenya, many rural hospitals lack the necessary oxygen equipment, reliable supply chains of oxygen cylinders, and stable electrical power required for oxygen delivery. The cost of oxygen in sub-Saharan Africa is high and fluctuates widely, influenced by the distance from production facilities. The gap between supply and demand for medical oxygen in LMICs remains vast. This shortage frustrates healthcare personnel, forcing them to make difficult decisions about who to prioritize for treatment. Patients too bear the burden of high treatment costs due to the lack of medical oxygen services. The African Population and Health Research Center, APHRC, conducted a study to assess the policy and institutional constraints affecting the availability and supply of medical oxygen in Kenya. Data was collected from 8 counties: Uasin Gishu, Bungoma, Kisii, Nyeri, Embu, Nairobi, Isiolo, and Nakuru. In this documentary, we share the lived experiences of patients who have benefited from medical oxygen and capture the perspectives of healthcare providers on access and utilization of medical oxygen in Bungoma and Uasin Gishu counties.
Nilikuwa kwa hospitali na ugonjwa wangu ikazidi, nikapewa rifaa mpaka Eldoret na walinipa oxygen pale Cheptais Hospital. Kwa hivyo oxygen ilinisaidia mimi wakati nilikuwa nimeshindwa kupumua.
Kweli mtoto ameumia miaka mingi. Juzi alilala siku 3 bila kukula. Akaanza sasa kukonjeka tena. Akapelekwa Cheptais.
Mtoto alienda kama ako hali mbaya. Immediately wakati walimpeleka ilibidi tuwamweka oxygen. Akasurvive na oxygen for almost 1 month. Kupumua ilikuwa shida.
Kwa hiyo alikuwa na shida ya kifua, pressure kama ilikuwa chini, alikuwa anapumua kwa chini sana. Ndio tukaona niri tulimlete hapa. Daktari alipofika ndio akaona pumzi iko chini, akamweka oxygen sasa.
Mtoto alikuwa na severe pneumonia. Alikuwa hali mbaya sana. That's why nilipofika Bad Forest, mtoto aliwekwa kwa oxygen na akahudumiwa.
Welcome to Webuye County Hospital. This is our oxygen processing plant that was installed in 2011. Actually, in this county, this is the only facility with an oxygen processing plant.
Cheptais sub-county we are serving as a referral center. We have had several occasions where patients needed oxygen, and we did so to them, and they also benefited from the same.
There's a day a patient came in. She had difficulty in breathing. Upon looking at the child, she needed oxygen. The ambulance was on standby with oxygen also, so we moved the child to the ambulance, and from the ambulance to MTRH after making calls and after having known sure that we are going to be received at MTRH.
This facility is serving as a referral center for both Kenya and Uganda, so the population makes oxygen demand high.
In Cheptais, respiratory conditions is among the 10 most common diseases, and one of the first line management of this condition is oxygen administration.
In the pediatric ward, we can use maybe oxygen at the average of 3 patients in a week.
In most cases, we tend to find the casualty or accident and emergency department demanding for more oxygen supply. In other cases, you can find the wards But in most cases, where I can attribute to large consumption of oxygen is normally the accident and emergency section, the casualty department. That is where there is huge demand for oxygen. The last servicing of our plant was done in November 2022. The next service was supposed to be November 2023, but so far the service provider, from the communication we have, is quite engaged at this point, and he has plans to do the service, but so far he has not arrived at the facility, but we're in communication in most cases. So we are still hoping that he beats the time, because since our plant is due for service, we have not been using it for fear of compromising the purity levels of oxygen being administered to the patients.
We have been purchasing oxygen from various companies outside this county. Surely it has not been easy because of transportation challenges. We need at least an oxygen plant in our county.
We have 2 suppliers. We have BOC, then we have Ox Plus. The challenge we have is the compatibility. If you want to refill BOC cylinder, if you take to Ox Plus, they won't do the refilling.
Flometers are very expensive, and our facility, we can't afford to purchase quality flometers. Another issue is about the oxygen administration, the accessories like the oxygen reservoir bags and also the oxygen administration tubes.
Ni vizuri oxygen ikuweko hospitali, sababu ninaona kama ingekuwa oxygen uende, mimi sijui kama ningekuwa.
Mi ningependa kaunti yetu governor, ningependa uwasilishe facilities za kutosha kwa hospitali zetu. Ningependa pia utujengee hospitali karibu na sisi.
Most of the patients we get in this hospital, they normally come as a referral from the peripheries, that's level 2 and level 3. So I think more oxygen should be put in those levels.
The HMT should ensure that its staff should be equipped with enough knowledge and skills to deliver oxygen to the patients.
What we have been doing in the last 12 months thereabout is to just look at the status that the country is in, look at the current availability, access and utilization of medical oxygen in our public facilities. There are certain things that government has done. For example, classification of medical oxygen as an essential medicine went a long way in ensuring that there is access because of the removal of tax. Some of the recommendations that we've given include looking at oxygen as a package and not necessarily as the gas itself. That way, then it's going to be possible to make sure that if taxation is removed from the other components, then it's possible to then lower the cost, the ultimate cost. And in the process, then it's possible for county governments to actually be more equipped, have access to medical oxygen more cheaply, and therefore citizens may have access more than they have had before.
APHRC brought together representatives from national and county governments, members of parliament, the Council of Governors, and industry partners to share crucial findings from the study. These recommendations pave the way for collaborative efforts to enhance the medical oxygen sector, ensuring better access and improved health outcomes for all.
We've done this work, and our appeal is that we've exposed what the gaps are. We've documented what the gaps are, both in terms of technicians, both in terms of the manufacturing value chain, both in terms of things like guidelines, what happens when a patient is admitted, who gets oxygen, when is it stopped. So there are many gaps really across the system. And our hope is that with all of us coming together, the government, the national government, the county governments, but also other stakeholders and investors, that we can actually solve the gaps that we identify in the value chain around oxygen, so that our babies, our mothers, ourselves, if we get accidents, can stand a chance to get the right care when we need it. And this is something which happens every day.